Today I'm going to be demonstrating how to manage when you are assessing a fracture. You want to use the plus discs acronym. So you want to look for, you want to assess for a pain score, assess for loss of movement, unnatural movement, swelling, deformities, irregularities, shortening of any limbs, and crepitus. And when you are assessing for crepitus, what you can do that by is just palpating. And so before we start managing the fracture, you want to get consent from the patient, and just to make sure that it's okay to expose the limb to be able to look at the full extent of the injury, and also the other limb to just compare. So now that both the limbs are exposed, we are going to check for neurological and cardiovascular integrity, which is sensation, colour, and also the cap refill. So before we start the splint, we're going to administer some pain relief, which in this case is going to be methoxyflurane. And contraindications of this are known renal problems, had it in the last week, and the patient can't obey commands. So we're just going to administer the pain relief and make sure they know to breathe in and out of it, and that they can use it because it's self-administered. There you go, have some pain relief. Alright, so now I'm going to start the splinting the fracture. So when splinting a fracture, I'm going to be using a box splint and a towel, and the towel is going to just add some more support to the fracture.
Yeah, roll it in. This part you can speed up.
Everyone can see all my rolls. To secure the splint to the limb, I'm going to use one triangle bandage proximal to the injury and one distal to the injury. And now going to place the triangle bandage distal to the injury. Now that I have managed this fracture, I'm going to reassess the pain score, as well as the cardiovascular and neurological integrity of the foot, as well as comparing it to the non-injured foot. Okay, so I'm going to be demonstrating how to apply a cervical C-spine collar. Okay, so now I'm going to demonstrate how to apply a cervical C-spine collar, and indications for applying one of these are present focal neurological deficits, such as tingling in the fingers and toes, as well as midline spinal tenderness, which you can palpate through the back of the neck, as well as altered level of consciousness, present intoxication, and other distracting injuries. Okay, so before I apply the C-spine collar, I'm going to explain what I'm doing with the patient and gain the consent to be able to put it on. I'm also going to call in my offsider to help me stabilise the head while I secure the collar to the person's neck. Anna, can you please bring me the C-spine and just stabilise his head for me? So when measuring the collar to the person's neck, you're going to measure from the mandible to the shoulder. So I'm now going to just adjust the C-spine collar. And now before I apply the C-spine collar, I'm just going to bend it to make sure that it applies to the patient's neck nicely. Place it around his neck and under his mandible, and then bring the back of it around. And then I'm going to do that. So we're going to have the C-spine collar not too tight so that you're hurting them, but not too loose so that's not. Okay, so now I'm going to be demonstrating basic airway management, and I'm going to start off by demonstrating how to use an OPA. Indications of using an OPA are GCS below 8, the patient who is unable to maintain their airway, unconsciousness, and head trauma. The benefits of using an OPA is that it has a bite piece which can help prevent jaw clenching. So I'm now going to demonstrate how to put it in, and first I'm going to measure the OPA. So I'm going to measure it from the bottom of the lips to the bottom of the mandible, and this one seems to fit perfectly. I am now going to place a towel under his neck for support. I'm going to place the OPA into the mouth with the bottom of the OPA facing towards his nose, and placing it down in, and then twisting it 180 degrees and scooping the tongue and placing it onto his lips. Some of the contraindications for using an OPA is if their gag reflex is still intact, if the patient has developed trismus or jaw clenching, or if their GCS is above 8. Complications when using the OPA, if you use the wrong size, it can cause tissue trauma to the oropharynx or the top of the mouth, and it can also induce vomiting. So now I'm going to demonstrate how to place an MPA. The indications for an MPA are semi-conscious patient or unconscious patient with an intact gag reflex, a patient who can't tolerate an OPA. The benefits of using an MPA are that you can suction through the MPA, can be used in patients with an intact gag reflex, trismus, or oral trauma. So I'm now going to demonstrate how to put the MPA in. So now I'm going to demonstrate how to put in the MPA. I'm first going to measure the MPA from the tip of the nose to the bottom of the earlobe. So I'm going to place it next to the face and just measure it, and that looks to be a good size. I am now going to grab the lube and put some onto the MPA. So I'm now going to choose the nostril that I'm going to use for the MPA, and normally the left nostril is bigger, and in this case it is. So I'm going to place it with the tip facing the septum, and I'm going to start placing it in the nose. So I'm going to now place the MPA into the left nostril and put it in at a 90-degree angle, and if there is any resistance met, I'm going to twist it gently and continue inserting it, and if there was any more resistance, I could try using the other nostril and just place it on the tip of the nostril. Contraindications for the MPA is a suspected base skull fracture or facial fractures and a responsive patient. Also, the complications for an MPA, if it's too short, it won't separate the soft palate from the pharynx, and if it's too long, it can aggravate a cough and the gag reflex, and it can also cause an episode, which is a nosebleed. So now I'm going to demonstrate how to manage a hemorrhage. Okay, Anna, so now I'm going to apply some dressing to your wound. Is that okay? Yep. Sweet. I am now going to expose the wound, but in this case it's already exposed, and if need be, I would clean it if it had any dirt or stones or anything in it, but it doesn't because it is just a clean cut lacer. So now I'm going to apply some dressing. I'm going to size it up and try and make it as small as possible, and then I'm going to moisten it with some saline so that it doesn't stick to the wound. Anna, can I just get you to hold this on your arm please with some pressure? Thank you. So now I'm going to grab a dressing and wrap it around her arm to stabilize the pressure around the wound. Can I just get you to hold that for me please, Anna? Thank you. And I'm going to wrap it around so that it's not too tight and not too loose, and occasionally we can do some twists in it if need be for added pressure. And then I'm just going to pop it in there and just tape it so that it stays. I'm now going to assess the cardiovascular and neurological integrity of her arm and check her pulse to make sure that my dressing isn't cut off her circulation. Can you feel it? Good. Colour looks good. Can I have your other hand please? Thank you. Both hands look similar in colour, and I will just take her pulse. So if the bleeding didn't stop after me applying the first dressing, we can go back and apply another gauze and bandage to apply more pressure to try and stop the bleeding. And also Anna can elevate her arm above her heart so that it can slow down the blood flow to the injury. So now if the bleeding hadn't stopped after the second set of dressing and elevation, I can apply a tourniquet, but this normally is the last resort. I would now explain to Anna what I'm going to do. So Anna, I'm going to apply a tourniquet. So now that I'm going to apply the tourniquet because the bleeding has not stopped, I need to re-expose the wound so that I can see it. So first off, before I apply the tourniquet, I'm going to give Anna some methoxyflurane because having the tourniquet applied can be quite painful. So Anna, if you take this pain relief here and just exhale through the whistle. I'm now going to grab the tourniquet and I'm going to apply it 10 centimeters proximal to the injury. I don't actually remember how to do this. And now I'm going to tighten the windlass. So for the purpose of this video, I'm not going to tighten the windlass, it's just for demonstration. I would tighten it and then lock it in place and document the time that it was applied, because once it has been applied, you can't take it off and then re-put it on. And so that the hospital knows how long that it's been on for. So now I'm going to demonstrate how to use the suction kit. The indications of using the suction would be if the patient is semi-unconscious to unconscious and has foreign fluid and substances in their oropharynx. I'm now going to test the kit before I start using it, so I'm going to turn it on, press test and occlude the tube. So now that we have tested the suction kit and made sure the batteries are fully charged, we can go ahead with suctioning. Okay, so I am now going to place the patient's head laterally. So now I'm going to start suctioning. I'm going to insert the rigid catheter into the oropharynx and only as far as I can see. I'm going to leave the circuit open as I enter the mouth and then close the circuit when suctioning on the way out, and only suctioning for 10 seconds at a time in circular motions. So I'm going to turn it on to full. Okay, so the complications of using the suction kit are that it can induce vomiting and bradycardia. The patient can't breathe whilst the suction kit is suctioning, and also you can't use the rigid catheter while in a moving vehicle. You need to use a soft catheter. So now I'm going to demonstrate how to deliver oxygen. Before we attach the regulator to the oxygen bottle, we are going to check the Brodox seal to make sure that it's nice and tight and isn't worn out. So looking in here, and it looks to be all intact. So I can now go and slide the regulator on, lining the 3 pins up and tightening the regulator a quarter turn at a time until it is finger tight. I'm now going to turn it on to check how much oxygen is in the bottle, and it is 3/4 full, so that's fine. I'm now going to attach the nasal prongs to the regulator. So I'm now going to turn the oxygen on and turn it on to between 2 to 4 litres, and in this case I'm going to use 2 litres. And now I'm going to attach the nasal prongs onto the patient. So putting it into the nostrils, loosening this, putting it into the nostrils, behind the ears, and tightening it under the chin. And once you have finished delivering your oxygen, you can untighten this, take the nasal prongs out of the nostrils, and turn the oxygen off. And to bleed the cylinder, we are going to detach the nasal prong tubing and bleed it out just by, and now I'm going to turn the dial on the regulator to bleed out the oxygen that is left in the regulator. And then turning it back to 0. So now I am going to demonstrate how to use a bag valve mask. First off, we are going to test the reservoir bag to make sure that it has no holes or leaks. We're going to attach it to the patient valve, and we are going to inflate the bag to see if it has any holes. So that seems to be working alright. So I am now going to attach the PEEP valve and the filter back on, and attach the reservoir to the reservoir valve. And then lastly, the mask onto the filter. And now I am going to insert the OPA, tilting the patient's head and twisting it 180 degrees. I'm now going to attach the oxygen onto the bag valve mask. Okay, so I've now attached the oxygen tubing, and I'm now going to turn it on to 15 litres per minute, administering 100% oxygen. I'm now going to place the bag valve mask onto the patient's face, holding it in a C shape, and administering a breath every 5 seconds. Also watching for equal chest inflation and making sure there's no gastric inflation. Okay, so now I'm going to demonstrate how to run an operational check on an MRX defib monitor. I'm now going to turn the defib monitor on and press menu, scroll down to other, and press operational check, and run operational check and acknowledge.
Give it the paper out.
And turning it to 150 kilojoules. Charge.
Shock delivered.
Yes. Okay, the operational check is now passed and it is printed. And rip this off and press exit object and turn it off. So now I'm going to demonstrate how to use the defib monitor, and in this case it's going to be an MRX 12 defib monitor. So before I turn it on, I'm going to check the batteries and change them if I need to. The buttons for checking the battery are at the back here. And in this case I don't need to change the batteries as they're all fully charged. I am now going to turn the monitor on. I'm now going to run a test defib in which I'm going to attach the test load and charge it to 50 joules. So I'm now going to press charge and press shock. I'm now going to disarm the charge, so I'm going to press charge, and down here I'm going to press disarm. So I'm now going to change it to AED mode.
Analyzing heart rhythm. Do not touch the patient. No shock advised. Pause. If needed, begin CPR.
So I am now going to demonstrate how to change between the leads. I am going to be the stimulator, so I'm going to attach the 3 leads onto myself. I'm now going to turn the monitor on. So I'm now going to go ahead and press this button here, which changes in between the pads and the leads. The reason that the monitor is showing a flat line on the pads currently is because the pads are only used for when shocking a patient. And so I'm now going to change it to a 3 lead. And my ECG is currently coming up on the screen. And now I'm going to go ahead and adjust the QRS volume, which is the beeping that's coming from the monitor. So I'm going to press menu, volume, and then scroll down to QRS, and can go very loud to not on, so I'm going to leave it on medium. Now I'm going to go ahead and adjust the ECG size, so I'm going to go ahead and press menu, scroll down to display waves, and then scroll down to press wave 3, and then press 3, and then I can adjust the size to make it as large or as small as I want, or have it on automatic, so I'm going to leave it on ×1. So I'm now going to go ahead and identify the non-invasive BP cuff button, which is here to start it, which I'm not going to as I'm only demonstrating, and the BP cuff lives in the back of the monitor. Also show you where the ET-CO2 detector lit is held, and it's held in this left pocket here, and it is just the clear tubing like so. I'm now going to demonstrate how to change the ECG paper. You just press this little grey button on the side, open it, attach, put in the paper with the pink side facing down, hold it out, and just press it back in. So this is the CPR puck, and it lives in this pocket here alongside the test load and the shock pads. So when the monitor is turned on, the monitor will default to the pad setting, which I showed you when changing the 3 lead. The items that are in this pouch here are the 3 leads, the attachment for the leads, the SpO2 detector, and the ET-CO2 detector. So when you're monitoring and one of the leads come off, it'll show that there's a flat line, as showed like this, and it shows that there's a flat line. So now I'm going to demonstrate the basic vital signs, and first off I'm going to start with heart rate and wrist rate. So Anna, is it alright if I take your heart rate?
Sure.
Thank you. Can I please have your arm? Thank you. So I'm now going to take her heart rate at the radial pulse for 15 seconds. So I've now felt her heart rate on the radial pulse, and it was about 20 beats per 15 seconds, and I times that by 4, which is 80. I also took her respiratory rate as well while I was doing the heart rate. I didn't tell Anna that I was doing the wrist rate because I didn't want her to change her breathing patterns, and her respiratory rate was about 4 breaths per 15 seconds, and that equates to being 16 breaths per minute. So now I'm going to take Anna's blood pressure. Anna, is that alright if I take your blood pressure? Yep, cool, thank you. So I'm now going to put the blood pressure cuff around Anna's hip. So now I'm going to pump the cuff up while feeling her radial pulse, and once I can't feel her radial pulse anymore, I'm going to give it one more squeeze of the little pump. So now I'm going to listen to Anna's blood pressure. So Anna's systolic blood pressure was 135 and her diastolic blood pressure was 75. And the normal systolic blood pressure is between 90 and 140. So this makes Anna's blood pressure relatively normal. She did state earlier that her blood pressure is relatively high normally, so this isn't a cause for concern. So I'm now going to demonstrate how to auscultate the lungs. So Anna, is it alright if I have a little listen to your lungs, and by doing this I need to lift up your shirt?
Yep, that's fine.
I'm now going to listen to the 4 regions of the lungs, starting at the top from left to right and then going to the bottom. Can you take a big breath in for me, Anna? Is it alright if I just get you to lift up the top? Yep. Thank you. And big breath in and out. And the other side. Thank you. Is it alright if I now do the back? And I'm just going to go down the back of your shirt. Alright, I'm just going to lift up the back of your shirt here. Big breath in. And another one. The other side. So I've now had a little listen to Anna's lungs, and there were no abnormal sounds such as wheezing, crackling, or wet sounds, and this indicates that Anna has good working lungs. So I'm now going to demonstrate how to auscultate the lungs. So Anna, is it alright if I have a little listen to your lungs, and by doing this I need to lift up your shirt?
Yep, that's fine.
So this is a demonstration of an AED CPR resus. We have been called to a patient that has collapsed and is unresponsive. There is one bystander who does not know the patient and doesn't know any medical information about them, such as their medical history. Right, coming onto the scene, checking to see if there are any risks or dangers. The scene is clear other than one bystander who does not know the patient or any of their information such as medical history. Right, checking to see if there's any responsiveness. Hello, sir, can you hear me? Hello, sir. Checking their airway is clear. Checking to see if they're breathing. They're not breathing, and checking the pulse. Anna, can you please start CPR? Confirming R49, requesting R50.
Copy.
Taking out the AED. Turning the AED on.
Analyzing heart rhythm. Do not touch the patient. Shock advised. Charging. Stay clear of patient.
Everyone stay clear.
Deliver shock now.
Shocking.
Press the orange button. The shock delivered. Pause. Start CPR.
pushing the oxygen to the BVM. Can you count for me, please, Anna? 21, 22, 23, 24, 25, 26, 27, 29. And start compressions. Start again.
Stop CPR. Analyzing heart rhythm. Stay clear of patient. Analyzing heart rhythm. No shock advised. Pause. If needed, start CPR.
Applying an IPA. 10, 12, 23, 24, 26, 27, 1, 2. 13, 14, 15, 29, 30. 1, 2. More, 25, 26, 27, 28, 29, 30. Just rise. 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. Twenty-one, 22, 23, 24, 25, 26, 27, 28, 29, 30.
Stop CPR. Analyzing heart rhythm. Stay clear of patient. Analyzing heart rhythm. No shock advised. Pause. If needed, start CPR.
Good chest raises. 3, 4, 12, 14, 15, 16, 17, 18, 19, 20, 21, 22, 29, 30. 1, 2. Good chest rise. So going to continue doing CPR until we achieve Ross. Or not. And we are going to continue swapping over doing CPR